This is The Broken Shift with Nurse Natalie. Healthcare doesn't break in chaos, it breaks quietly. People hear a nurse say she's angry about having to move extremely heavy patients, and they immediately assume the problem is compassion. But that's not the real problem. The real problem is that healthcare systems still expect nurses to risk permanent injury doing work that should never depend on raw human strength in the first place. OSHA says there is no such thing as safe manual lifting of a patient. And the National Institute for Occupational Safety and Health identifies patients handling as a major source of musculoskeletal injury for healthcare workers. And that is the part the public often misses, because this is not really a story about attitude. It is a story about unsafe systems, preventable injuries, and a profession that has been conditioned to sacrifice its own body in the name of care. The American Nurses Association says its goal is the complete elimination of manual patient handling, precisely because of the harm these tasks can cause to both nurses and patients. And here's the story behind that anger. An anonymous nurse recently shared a truth that clearly struck a nerve across healthcare. She said what many nurses think but are often afraid to say out loud: that it does not make you a bad nurse to feel angry about destroying your body, moving extremely obese patients. Not because patients do not deserve care, not because nurses should shame people. That's not it at all. But because repeatedly repositioning, boosting, transferring, and catching very heavy patients can leave nurses with permanent back, shoulder, neck, and knee injuries. And judging by the reaction from other nurses, this is not some fringe complaint. It is a widespread experience. That emotional truth lines up with what federal safety agencies have said for years. Manual patient handling is hazardous, and lifting, repositioning, and transferring are among the most common patient-related tasks that lead to injury. This is not a character problem, it's a system problem. The easiest way to dismiss this conversation is to turn it into a moral argument. To say if you were more compassionate, you would not feel frustrated. But listen, frustration is not the real scandal here. The real scandal is that hospitals have known for years that patient handling injures nurses, and yet many facilities still fail to provide the staffing equipment, room design, and lift culture needed to make care safe. OSHA's Safe Patient Handling Guidance says employers should develop and implement assessments, policies, procedures, programs, training, and patient education around safe patient handling. That means the issue is bigger than one nurse, one patient, or one difficult shift. It is about whether the system is built to protect the worker doing the job. And too often it isn't. And there's a myth about just using proper body mechanics. One of the biggest lies nurses have been fed is that if they just lift correctly, they'll be fine. Use good body mechanics. Bend at the knees. Keep the patient close. Don't twist. But OSHA is very clear on this. Proper body mechanics by itself is not an effective way to reduce injuries. And it explicitly states there is no such thing as safe manual lifting of a patient. OSHA's hospital e-tools says the same thing. Focusing solely on body mechanics is not sufficient to prevent musculoskeletal disorders. That matters because nurses have been trained to internalize blame. If they get hurt, they are often made to feel like they lifted wrong, moved wrong, positioned wrong, instead of asking the more honest question: why was a nurse placed in a situation where human muscle was expected to solve an engineering problem. Safe patient care is not just about willingness. It is about infrastructure. If a patient requires multiple people, the multiple people should be available. If a patient requires a mechanical lift, the lift should be on the unit and functional. If a patient requires bariatric equipment, the room should be designed for it. And if none of those things are available, then the delay is not a bedside nurse failure. It is a system failure. The National Institute of Occupational Safety and Health recommends safe patient handling and mobility technology, including assistive lifting devices, as part of injury prevention. American Nurses Association says safe patient handling mobility programs reduce risk for both workers and patients while improving care quality. This is where a lot of nurses get trapped psychologically because they know the patient still needs help. They know the patient is uncomfortable. They know the family is watching. And they know administration loves to turn system failures into bedside guilt. So they do the unsafe move anyway. And sometimes they pay for it with their spine. Healthcare loves to talk about resilience, but it does not talk nearly enough about cumulative damage. Micro injuries, the shoulder that never felt quite right again, the back pain that started as soreness and became chronic, the disc injury that ended a bedside career at 30, 35, or 45. The Bureau of Labor and Statistics has reported that sprains, strains, and tears make up the largest share of injuries and illnesses among registered nurses, and those injuries frequently lead to days away from work. This is part of why this topic matters so much, because the damage is often normalized until it becomes permanent. And by then, the nurse is the one left navigating workers' comp, lost income, pain management, physical therapy, or a forced career change. The hospital keeps moving. The body doesn't. Bariatric care is real care, which means it requires real resources. A patient with severe obesity still deserves dignity, safety, and excellent nursing care. That should not even be up for debate. But dignified care is not the same thing as pretending the physical demands are minor. Bariatric care often requires more staff, more time, larger rooms, specialized beds, ceiling lifts, lateral transfer devices, and intentional planning. Without those supports, the system is effectively asking nurses to make up the difference with their own bodies. OSHA and the ANA both emphasize that mechanical lifting technology and comprehensive safe patient handling programs are central to safer care for both patient and worker. So when a nurse says, "I'm angry," what she may really mean is, "I'm tired of being treated like disposable equipment." The public often misunderstands the anger. This is where the conversation gets really uncomfortable, because the public hears anger and assumes cruelty. But in many cases, the anger is not actually directed at the patient as a human being. Not at all. It is directed at the impossible position nurses are placed in. The impossible expectation that they should provide bariatric level care without bariatric level support. That they should absorb violence from sudden grabs, catches, buckling knees, and unsafe transfers without reaction. That they should risk lifelong disability and still smile through it. That is not compassion. That is exploitation. And the profession has normalized it for far too long. There is also a deeper cultural layer here. Nursing has been shaped by a martyr mindset for generations. Push through, don't complain, do whatever it takes. Put the patient first, no matter what it costs you. But no other safety-sensitive profession is expected to destroy its workers in order to prove compassion. Truck drivers are not told to blow out their backs. Warehouse workers are given lift limits and mechanical support. Firefighters train for team lifts and scene safety. Yet in healthcare, nurses are still routinely made to feel selfish for refusing an unsafe move, even though OSHA's guidance is clear that manual lifting should be minimized and eliminated when possible. So the message becomes, your body is part of the equipment, and that message is deeply dangerous. Most nurses are not asking for permission to be callous. They are asking for permission to be safe. To say, I will care for this patient, but I will not knowingly injure myself to do it. I will wait for enough staff. I will wait for the lift. I will escalate. I will chart the delay. I will not let guilt override safety. That is not bad nursing. That is professional judgment in an unsafe system. And frankly, it is more ethical than pretending a dangerous lift is acceptable just because the culture says to make it work. If hospitals were serious about protecting nurses, they would stop relying on body mechanics, posters, and annual modules as the solution. They would invest in real safe patient handling programs. They would track injury trends. They would purchase and maintain lifting equipment. They would design bariatric capable rooms. They would staff according to patient mobility needs, not just headcount. And they would make it culturally acceptable for nurses to stop and say, this is not safe with the resources currently available. OSHA's safe patient handling resources are aimed exactly at helping hospitals build those kinds of programs. And the ANA advocates for the elimination of manual patient handling as the benchmark. The problem is not that patients need care. The problem is that hospitals often fail to provide the staff, equipment, and systems required to deliver the care safely. And when that happens, the burden gets transferred downward onto the nurse, onto the tech, onto the aide, onto the body of the worker who is expected to absorb the risk quietly. That is why this conversation matters, because nurses should not have to choose between protecting a patient and protecting their own spine. A safe system should protect both. A nurse is not a Hoyer lift. A nurse is not a ceiling track. A nurse is not a piece of furniture. And the more healthcare systems forget that, the more nurses they will break. This is The Broken Shift. Hit that like button, subscribe, and I'll see you in the next one. Healthcare culture doesn't change when we ignore it. It changes when we're willing to examine it. This is The Broken Shift.